Good morning and thanks for joining us for Close Up. I'm Steve Botari in for Adam Sexton. With the big beautiful bill in Washington and the newly signed state budget in Concord, healthcare policy and costs are back in the forefront. And to discuss that and the state of healthcare in New Hampshire, we're joined this morning by Dr. Joanne Conroy, President and CEO of Dartmouth Health. Dr. Conroy, thanks for being here with us this morning.
Thank you, Steve. It's great to be here.
So I want to start with what just passed in the nation's capital, the big beautiful bill and the changes we're seeing to Medicaid. Firstly, I know that Dartmouth Health is the state's largest provider for Medicaid patients. Give us a sense of what that looks like here in the Granite State when it comes to your patients with Medicaid, how many we're talking about, and what that care looks like.
There are approximately 185,000 people in the state of New Hampshire on Medicaid. Approximately 50% of them are children. They also include people that are disabled, often people that are older and need both Medicaid and Medicare to address their health care needs. We take care of about we take care of more patients than anybody in the state who are on Medicaid. 15% of all the patients we take care of are on Medicaid. Last year, that was 90,000 individuals across the state that we delivered care to.
And in this newly signed law, it slashes the budget for Medicaid by nearly $1 trillion over a decade, institutes these new work requirements and verifications. Those who are very strongly for this say it's going to root out fraud and waste and allow those precious resources to go towards those who need it most. Those against it say this could lead to the CBO estimate is 11.8 million people losing their health care coverage nationwide. What's your assessment of what these changes will mean for your hospital and what it could mean for your patients?
It was interesting as they were going through the bill process that they actually focused on beneficiaries and not benefits. And that was identifying what beneficiaries should receive Medicaid. I think for us, our challenges are going to be that close to 19,000 people by Kaiser Family Foundation may actually lose coverage. What this means is that people will go to their appointments and realize that they don't have Medicaid coverage anymore. And then most patients will just turn away. They don't have the resources to pay for that care. Then they'll get sicker and sicker and they'll end up in our emergency room. So our fear is that we're going to have people with illnesses that could have been taken care of before if they had appropriate coverage in our emergency rooms. And if anybody's ever been to an emergency room in New Hampshire in the last couple of years, you realize that they are incredibly full. Yep. And we just can see this being an incredible challenge for people that really need the emergency room, but also those patients that are going to delay care.
And I saw New Hampshire Hospital Association pointed out that those on Medicaid make up a significant portion of the folks who seek out mental health assistance or substance use disorder treatment. Are there concerns with that and what could happen with the ripple effects there?
Many of our patients who have a diagnosis of behavioral health are supported by Medicaid. And what you don't want are those people not seeking care and not getting the medication they need, because that affects everybody, their families, and the communities that they live in.
And here at the state level, I wanted to follow up on what we saw in terms of the budget that just passed, signed into law. Now, reimbursement rates did come up as part of the conversation in the House, at least, when they were looking for places to trim the budget. The final product ended up raising state Medicaid premiums and co-pays. How do you view what ultimately passed out of Concord and kind of where that was and what we ended up with?
What they really did focus on initially was work requirements and decided to align them with the federal government. And that means we're going to see the impact of that probably in 2027. They did add co-pays. They did add some premium costs for people in certain income levels. I think my concern is that those people may not actually seek care. We don't think about the fact that a copay of $25 may be a barrier for people going to see their primary care provider. And then the trickle-down effect is hypertension that's not treated, diabetes that they're not taking their medications appropriately, behavioral health issues that aren't addressed, even the issues associated with getting their pharmaceuticals to take care of their chronic illnesses.
Another thing at the federal level we've seen Dartmouth talk about is the cuts we've been seeing to research funding nationwide. Dartmouth is our state's only academic medical center. Has any of your research been affected by cuts at this point?
We've had some of our research not funded. What is more prevalent is that the call for research is actually eliminated, meaning they would normally have certain calls for papers and proposals, so they would actually review them and fund them. That's kind of gone away. So there are very few call for proposals that are going out. That impacts the amount of research we do down the road. If we actually don't do the early research now, who knows what the impact is going to be on the advancement of medical science. If you think about it, the work that was done on the spike protein, which allowed us to develop the COVID vaccine, was done at Dartmouth, but it was done almost 10 years ago. So sometimes you don't appreciate the impact of some of this work until you actually need it. And without that, we would never have been able to get the vaccine to market within a year.
So your concern is down the road, we're going to be kind of dealt with the lack of research in some ways that you see this. Do you see over the next few years even less research happening at Dartmouth as a result of this, or are you going to have to find the funding from other places, and does it exist?
Our researchers are pretty good at pivoting and identifying areas that people want to do research in. But right now, the NIH is getting smaller rather than bigger. And the question is, are pharmaceutical companies and our other foundations actually supporting research? And we, along with every other academic medical center, are trying to figure out what are the other avenues to continue our research. The Proudy that was just held this week, we made $10.1 million. A lot of that goes into beginning research for our promising cancer researchers.
And now we're seeing, I know, the potential for future cuts. We've seen these initial cuts. Part of that, too, is reported last month that Dartmouth Health Medical Center and the clinics are instituting a hiring pause. You cite the potential cuts to Medicaid and the research funding. How long do you anticipate that pause lasting?
You know, we appreciate there are a lot of unknowns out in the environment. What's going to happen with the NIH? What will be the real impact on people that are uninsured in the state of New Hampshire that we will still provide care for? With all those unknowns, we think the best plan is to just kind of cinch on our bed a little bit and hold our horses on growth and hiring so we can actually develop a level of resilience, financial resilience for the future.
Now, obviously, in many ways, Dartmouth Health is bellwether. It's the largest private employer in the state. For years, we've talked about the recruiting challenges, obviously. Does this make it even tougher to try to recruit folks up here to the state if we're doing this hiring pause? I know it's not affecting the frontline clinical workers and super necessary pieces, but already we're looking at a workforce struggle when it comes to healthcare.
Fortunately, we've had a lot of people apply for jobs, and actually our turnover rate continues to go down, and we're almost to the pre-pandemic levels. We still have a lot of catching up to do because we lost workforce across northern New England during the pandemic. But we are hopeful that people have decided to actually come to New Hampshire and live and raise their families. And of all the academic medical centers that people could choose to work for, we seem to be increasingly attractive to people from other areas of New England and the Mid-Atlantic states.
And now, how is Dartmouth Health navigating the housing crisis with all of this? Because I remember listening to you all speak at a forum of some rural healthcare leaders, and one of the big things was that even high-paying positions like anesthesiologists were having to turn it down because they couldn't find housing for their family in places like the Upper Valley. How do you mitigate that?
Yeah, so we actually have a service that seeks out available housing for people that are actually coming to us. We support housing in a apartment development across the street. So for a couple of years, if you're a frontline professional, we help subsidize your housing based on your income. And we are talking to people about the community about building houses and thinking about how can we do that in a kind of a sustainable way. And we're having those conversations across our health system.
Is that still kind of one of the main pain points when it comes to recruiting for New Hampshire, is the housing situation?
It's amazing that the cost of a house is $550,000 in New Hampshire, And it's not only the cost, though, it's the availability.
Yeah.
And that's what we're trying to work with community partners. No matter how well funded you are or how well organized you are, you can't do this without working with your community partners. And Vital Communities in the Upper Valley has been really wonderful, bringing CEOs together from all the industries in the Upper Valley and say, how can we solve this together?
And I know, Doctor, one of the things that makes Dartmouth unique is the fact that there's this focus on rural medicine and academic medical center, but obviously our state is pretty rural. Folks are spread out, aging population. I was curious, you know, after the pandemic, we saw telemedicine really take off, and it seems like people are using that for these everyday appointments more and more, now that they're comfortable with it. How do you see AI jumping into rural medicine and changing the game, if at all?
You know, AI is going to support all of our caregivers. When we think about how we utilize it, first of all, about 12% of our appointments across the board are currently telehealth. About 80% of our behavioral health appointments are by telehealth. So we know there's a subsegment of our population that's really embraced it. The question is, how can you actually use this to help the caregiver while they're delivering care wherever they're doing that? We are investing in the ambient listening technology, where a physician or advanced practice provider will dictate a note while talking to the patient in the room, and it automatically goes into the record. And that saves them both time, but also captures that human interaction of actually talking to the patient instead of talking to the computer. We are looking for a number of other technologies to actually improve our access. For example, there's a lot of artificial intelligence chatbots that you can talk to that will help you find an appointment. And if we can actually make that one call and one appointment for that patient, it doesn't really matter whether or not they're talking to a chatbot.
Right.
We've fulfilled what they wanted to do, just get an appointment with one of our providers. The technology is actually improving. I try to really reassure our employees, though, that we're not replacing them with technology, but we are replacing vacancies with technology. When we can't hire people, that puts a burden on everybody else on the team. Can we use technology to fill that void?
And then I want to ask you, when it comes to AI, does it then require a lot of capital expenses to then invest in these systems? We know how expensive, you know, things like Epic and all the systems are for healthcare, and then all the IT systems to protect all that around it. When it comes to AI, is it a big investment right now?
AI will be a bigger and bigger investment. However, we know that the safest way is actually build it on our existing technologies. So when we purchase a product, we're trying to make sure it's actually compatible with our Epic system, and it can sit on top of the system and actually be protected by the same cybersecurity we have around our Epic system. Cybersecurity is still a huge issue for us, as it is for any healthcare system. And we're working with really trusted partners in order to build these systems of care using AI.
It'll be really interesting to see how it all plays out over the next few years when it comes to our healthcare.
Yeah.
Dr. Conroy, thanks for joining us for this conversation this morning.
Thank you, Steve.
Appreciate it. And when we come back, teaching financial literacy to New Hampshire kids, the new program in Manchester schools.